Now that you've heard an overview of all that's entailed in the Affordable Care Act as it applies to the state, we have the right person here from the state to talk about how they're doing it and how it's progressing and so on. And so I'm pleased to have Len Finocchio. He's the Associate Director of the California Department of Health Services, where he focuses on the Medi-Cal program and the state implementation of the Affordable Care Act. Len received his Doctor of Public Health degree from the University of Michigan at Ann Arbor, and he's also taught a number of policy courses at various colleges in California. So please join me in welcoming Len.
Thanks, Paul. Good afternoon, everyone. Thanks for having me back again. I was here last year and enjoyed that, so it's nice to be back. So like Marion, I'm going to provide something of an overview of the Medi-Cal program. I know for some of you it will be, you know the program well. For some, you may not know it very well at all. So I'm trying to strike that balance between teaching some of you something new about Medi-Cal and for others, hopefully not to put you to sleep. There are a number of things that Marion covered that I'll skip over in my presentation because some of them are the same. And I do have a couple of forecasts at the end. But I really will try and spend my time focusing on kind of the ins and outs of what implementing the Affordable Care Act actually means and what it looks like and what we struggle with every day and how challenging it's been. So big picture of what is the Medi-Cal program. Provides affordable coverage to kids, adults, and persons with disabilities. So these really are the most vulnerable folks in California. Fills a gap in Medicare coverage for low-income Medicare beneficiaries. So as Marion mentioned, these are the dually eligible. So you're in Medicare, but you're so poor you can't pay your premiums, your Part B, and so on. So Medi-Cal backfills and pays that for you. Promotes keeping commercial premiums affordable. So as all of you know, if the uninsured are ending up in your hospitals, in your facility, you cost shift to commercial payers. So where Medi-Cal can provide insurance, we prevent that cost shift from happening. We pull in a lot of federal financial support to the safety net and to facilities, clinics, hospitals all over California. We provide care to 2 out of 3 nursing home residents. 2/3 of funding for public hospitals, and over half of all funding to community health centers comes through the Medi-Cal program. This is what Marion mentioned earlier, is who's covered in California and who is not, and by what insurance source. The most important thing to note here is that 1 in 5 Californians is covered by Medi-Cal. Another big picture overview, 52% of our beneficiaries are kids. So now, in last year's budget, the Healthy Families program is being transferred into Medi-Cal. So all kids up to 250% of poverty are covered in Medi-Cal by the end of this year. 56% are your neighbors, live here in Southern California. 54% are Hispanic. 47%, and this is an access issue which many of you, I'm sure, are thinking about or deal with on a daily basis if you're clinicians. 47% have a primary language other than English. So another key data point about the importance of Medi-Cal. Medi-Cal pays for 49% of all births in California. 49%. Murmuring. So the political science classes, the demography classes can talk about why. So Medi-Cal covers pregnancy up to 200% of the federal poverty level. And when you have time later to study this more carefully, those boxes point out where there are policy changes made, both at the federal level and the state level, which pushed that curve up, right? There's also demographic factors happening as well. So when the economy is not doing well, more people are in poverty, so therefore they rely on Medicaid, which I'll share with you in a moment. But what I want you to take away from this is the importance of policy changes and how dynamic these programs are. Every year there are changes made to Medicaid at the federal level, at the state level, same with Medicare, as I'll show a little bit later. And so this is going to continue happening year after year after year. So the takeaway from this slide is the red line is the unemployment rate in California, and as you see, as the unemployment goes up, enrollment in Medicaid goes up, which is it's a program designed to take care of those who are very low income. So over the past 4 years during the economic recession, people lost their jobs, they lost their employer-sponsored insurance, nowhere to go. If they're eligible for Medi-Cal, they would enroll. So we are really a safety net, and it's counter-cyclical. So when the economy is doing really well, our enrollment can go down. But when the economy is struggling and people are struggling and they need insurance, they end up on Medicaid if they're eligible. So this was a survey that was done by the California Healthcare Foundation, where they did a random digit dial of 1,100 beneficiaries. We did this in partnership with the foundation to really get into, so how do beneficiaries actually perceive the program? There's lots of things said good about Medi-Cal. There are lots of things said bad about Medi-Cal. We thought, well, let's go to the source and ask the people who actually are beneficiaries rather than just providers or policymakers. And over 90% felt it was a very good or good program. So it's serving their needs. Not serving all their needs, it's serving most of their needs well. Perceptions of coverage they get, the question was, do you agree or disagree that Medi-Cal covers most of the care that you need? Most agree that they are getting their care met. When we get into access to specialists, then it's a different story. So beneficiaries tend to have some difficulty getting access to specialists. Number of different reasons there. Specialists may not be participating as Medi-Cal providers, and the rates we pay compared to commercial rates or Medicare rates are much lower. So it's less attractive to participate as a provider in Medi-Cal. So the state budget, the program talked about Medi-Cal in the time of state budget deficit. That was last year, and the year before, and the year before, and the year before. So I'm here with at least more of a smile on my face this year than I was last year, because depending on what happens over the next few months as we get toward May revise the budget, the governor's budget message was we have a budget that lives within its means, finally, after many of years of deficit. It also noted that after 2 years of budget cuts in the Medi-Cal program and other programs statewide, and the passage of Prop 30, finally got into a place where we can start thinking about a balanced budget. The increase in K through 12 and higher education funding, so all of you who are University of California should rest a little bit easier. And also making a commitment to long-term fiscal responsibility at the state level. Also commits to health services for vulnerable Californians by continuing to fully fund the Medi-Cal program, although with some nuances, which I'll share later, and implements the Affordable Care Act. And, as Marion noted and has been noted earlier, that the Supreme Court made the expansion of Medicaid optional. So, and as you heard yesterday, Florida Governor Scott, after saying that he would never do the Medicaid expansion, never, finally did. Any hypothesis as to why? Former hospital executive, right? ACA, it's like, oh, dollars for hospitals. So anyway, he put 2 and 2 together. So many challenges and things to think about. What does it mean to actually implement from a financial perspective, from a policy perspective? It's very complicated, and lots of things to think about as far as financing. How do we pay for this in the years where the state will be responsible for 10% of the Medicaid expansion? So in the budget, $63 billion for the Department of Healthcare Services and the other programs that we have. Largely what we do is the Medi-Cal program, but we have other family planning programs and other public health related programs that we also run. The caseload in Medi-Cal is increasing by about 6%, and that's mostly due to moving about 900,000 healthy family kids into Medi-Cal. The general fund growth is about 4%. It would have been 8%, except for some changes and reductions that we are hoping to maintain. There were rate reductions that were put into effect a number of years ago, and there's been lots of litigation, and actually an issue that went all the way to the Supreme Court and actually sent back to the lower courts to revisit. We feel confident that we'll still be able to maintain these 10% rate cuts. There's an extension of the hospital fee, which allows all of this to be funded. Moving to diagnostic-related group funding for our fee-for-service hospitals, and a gross premium tax. This is probably more in the weeds than most of you are interested in, but I wanted to provide some budget detail. We're also, with moving healthy families, kids into Medi-Cal, the goal here is streamlining policy and also streamlining government so it's more efficient to have fewer boxes on the org chart that are doing similar things. So we've moved the Department of Mental Health, has been absorbed into the Department of Healthcare Services. That happened last year. And now this year, we'll move the Department of Alcohol and Drug Programs also into DHCS. And so another rationale for that is as we begin to think through the integration of physical health, and behavioral health, right? So the Affordable Care Act requires mental health parity. These programs will now all live under one roof. So we now have the conversations every day about behavioral health and what does that mean? How do you integrate services rather than those conversations happening in a building across town in Sacramento. Continuing to advance managed care efficiency, so we are moving to have all of our rural areas in California, which still are largely we pay fee for service, is moving our beneficiaries in rural areas into managed care plans. And lastly, we've been working for a couple of years now on a coordinated care initiative where we will try and coordinate the services, payment, monitoring of our dually eligible, so those Medicare beneficiaries in California who are very poor, and also Medi-Cal beneficiaries. As you might imagine, Medicare is the primary payer, but Medi-Cal is the secondary payer, and often the two aren't well coordinated. So this is an effort to coordinate the care for Medicare dually eligible beneficiaries in a way that saves costs over time and provides better services to them. Very busy pie chart. About 35% of what we spend is on managed care plans, 18% on inpatient hospital. That's all fee for service. So buried in the big blue slice of the pie there in managed care is also hospital services and physician services and all their subcontracts to their networks. So here's what I spend most of my time working on and waking up late at night and worrying about is implementing the Affordable Care Act. So this is just a graphic depiction of what the Affordable Care Act does. Across the top is the federal poverty level. So Medicaid in California will now cover people who are eligible, and I'll talk about that in a moment, up to 138% of the federal poverty level. CHIP, which you would know as Healthy Families Program, that's the Children's Health Insurance Program, covers kids up to 250%. So Medi-Cal will go up to 250% of the federal poverty level. You can also have coverage and subsidies in the exchange, which Marion was describing, up to 400% of poverty. Right? So you'll get subsidies to pay for your premiums and cost-sharing reductions to help reduce your cost sharing up to 400%. Now, what I want to point out is an area where, when I wake up at night, this is what I worry about. This. So between where the kids end and the adults begin. Right? So this group right here are families who will have parents in the exchange and kids on Medi-Cal. So not a tidy package of you're either in the exchange or you're either in Medi-Cal. You could be both. So from a policy perspective, we think about this a lot. How do you create good public policy that makes their lives as easy and coordinated as possible? How do you educate them as to what they're eligible for? How do you make sure that, or at least attempt to have them in the same plan? Right? So if the kids are in a plan that's a Medi-Cal only plan, and the parents are in a plan that doesn't participate in Medi-Cal, it's not the end of the world, but then you have all these different cards and benefits and cost sharing and co-pays, which is just a challenge. So always trying to think through how do we make this as easy as possible on families. So the governor's budget does have $350 million placeholder for expanding Medi-Cal, and this is for those who are currently eligible but not enrolled. So Marion laid out about 1.2 million people. So these folks who are eligible but they're not enrolled, they don't know about the program, they don't have need for health services at the moment, or they just haven't, the enrollment process is not easy, or they've tried and thought, I just can't be bothered, I'm not gonna do it. I'm not in need enough to go through the process. So, and the governor has committed to the full Medicaid expansion, even the part that the Supreme Court made optional, which is to childless adults. The term always bothers me when I say that, but that's how we refer to them. So these are non-family, so largely adults without kids. And we're in the process of having a conversation now of how do we pay for this, which is very challenging. So for the first 3 years, this expansion group is fully paid for by the federal government, 100%, no state dollars. Some administrative dollars, but all of their costs will be paid for. Starting in 2016, that rate goes down to 95, and then 93, and then 92, and then 90% by 2020, and the state is on the hook for 10% of all the costs associated with the expansion population. So now the state, through realignment, I won't get too much into detail on that, provides dollars to counties to provide care to the medically indigent or the uninsured now. So we're trying to sort out, so how do we take care of that 10%? Where some dollars already go to counties, do we take those monies back from counties and pay for this population? Counties will say there is a lot of other need after that population is enrolled in Medi-Cal. There's a lot more need that those dollars could be used for. So these are very complicated discussions between the state, the administration, the legislature, and counties. Through a federal waiver, we have an early expansion of our Medi-Cal population to these childless adults at the county level. To date, about 640,000 have been enrolled at one point. Now it's about 550,000 who are already enrolled. So of those who are going to be eligible to enroll in Medi-Cal starting January 1st, 2014, we already have about a third of them that are being taken care of by counties, right here in Orange County as well. So changes to eligibility, one of the goals, the congressional intent of the Affordable Care Act is to make enrollment into subsidized programs much easier. It's fairly complicated to get enrolled into Medi-Cal. So what they've done is they always ask your income and your family size. Now what they're going to do is peg it to your tax returns. Right, so all of you are probably working on it, or should be working on it soon. And at the very bottom line, it always says adjusted gross income. So the feds will take your adjusted gross income and make a few modifications to it and make those data available on what's called the Federal Data Services Hub. This gets into how we're going to do enrollment in the future. So you can say in the application for Medi-Cal or for premium tax credits in the exchange, I make this much money. It'll go to the IRS Federal Hub and find your income and say, oh yeah, that's you. That's all we need to know about your income. So trying to modernize it and make it as streamlined as possible. You can also do what's called self-attestation of who you are, where do you live, how much money do you make. And our responsibility is to find information about you electronically so you don't have to do any more work. Right, we'll go to Homeland Security to find your immigration information or your social security number, find where your residency, to make this as easy as possible, but also for program integrity reasons, to make sure you are who you say you are, to deal with fraud and other things. So the Affordable Care Act is very clear in federal rules about this should be a no wrong door approach to enrollment. You can enroll online, you can send in an application by mail, you can pick up the phone and call the service center, or you can go in person. And enrollment in Medi-Cal now is mostly done in county social services offices and will remain that way. But there are now 3 other ways you can enroll in insurance. Marion talked about that. 5 more minutes, okay? So who is the new Medi-Cal population? Predominantly working age, 18 to 44 years old. Again, childless adults, where it says 1 in 3 have kids. Their kids are probably already enrolled in Medi-Cal. Right, so they know their kids are insured, they are not. Predominantly people of color, about 40% are Latino. 1 in 4 does not speak English well. Again, so when we talk about outreach and enrollment and assistance, that has to be kept in mind, and are either unemployed or self-employed. So where do we spend our time? As Marion mentioned, there's a special session of the legislature that is underway right now, addressing all of the issues of eligibility and the expansion itself, having discussions with many stakeholders on how do we do this expansion in a way which is financially sustainable. We're extensively collaborating with the exchange. We are sharing the ownership of and management of and oversight of this new enrollment system that's being built by Accenture, which is a very ambitious build that has to be operational by October 1st to do pre-enrollment. We're also working closely with our county partners who we're going to do a lot of the heavy lifting on helping people get enrolled. And we've also are working on the implementation of a rate increase to primary care providers, so up to Medicare rates. So very quickly, 2 big forecasts, or as Marion said, rather than forecasts, kind of common sense observations about where we're at. Plus ça change, plus c'est la même chose, which is, it basically says, oh, as much as everything changes, it really stays the same. Not at all. So to illustrate, this is a chart of all the different changes that have happened to Medicaid since its implementation in 1965. Something or a couple of things every year, right, at the federal level and the state level. This is a short list of things that have changed legislatively to Medicare. And so not a forecast, it's an observation of how are we going to fill in what this is going to look like over the next 5 or 2, 3, 10, 25, 40 years for the Affordable Care Act. Congress will be tinkering with it, I'm sure, quite a bit for a long time, which makes our job fun and challenging and somewhat unpredictable. So what are some of the things that may actually cause change? The boom or bust cycle in our state budget. While we have a balanced budget now, who knows what's going to happen with sequester? It seems very fragile. What if the economy doesn't do so well? What if there's a double-dip recession? Things change quickly. What happens in DC around the sequester and other budget reductions, I'm sure there will be challenges to what exactly are essential health benefits. We get emails and calls every day from the autism folks, which is a very difficult, challenging area of service about what are you going to do for autism, what services are you going to provide. And then my inbox are from lots of other groups, the Lymphoma Society. So what's provided through insurance is very important and means a lot to a lot of people. And so what benefits we provide and to whom, I'm sure will be an area where we're going to be talking about and may change for a long time. And lastly, I'll just spend a few minutes on, and I titled this forecast, the enrollment evolution. So a lot of folks are hoping this will be a revolution of the way you enroll into benefits. It's going to be a lot easier. Will it be revolutionary? I think the revolution will come many years down the road, but it's going to be a slow evolution and improvement. This is how people enroll into Medi-Cal now. I'll just point you to the last bar on the right. 74% do it in person. You go to a county office, you sit in a chair and you wait, call your number, you go through the application. Only 11% are done online. These numbers are all going to change actually quite dramatically, but is it going to be on January 1st? No, it's going to take a year or two to see dramatic changes in the way people are enrolling. But it's going to happen, it's going to go slowly. This just says people don't mind the experience at county offices. It just takes too long to wait. There is an online application now for healthy families, but only about 32% of beneficiaries actually use it to enroll. Most of them are English speaking. So the big challenge is how do you provide an online enrollment experience about very complicated eligibility issues and health plan choices in a way that's user-friendly and easy to navigate. So this is what Accenture is working on with a number of other subcontractors on just how do you design this website to do this well. So some of you have probably seen eHealth Insurance or Get Insured. Actually, Get Insured is one of the subcontractors helping us think, how do we design this in a way that's appealing, intuitive, and easy to use? Now I have 1 minute. Some states, Oklahoma, 95% of people enroll into Medicaid online, so it is doable. It just takes some time. And I think another, rather than going each of these slides, I think the main takeaway is that in this survey, people said, yeah, doing it online would be great, but I want to be able to pick up the phone when I get to a question of something that's really challenging. What's an actuarial value? How many of you know what that is? Okay, good. But most folks don't. Like, what is this? What is this? The gold level and premium? What are these metal levels? What is cost sharing reduction? I don't get it. So rather than having to sort that out with mouse overs and things like that, they want to pick up the phone or they want to go sit with somebody to have it explained to them. So ways into coverage, this online portal that we're designing with Accenture. The counties have portals that will also be in use. You can go into a county office to enroll. Big network of community-based assisters and churches and community-based organizations who will help you enroll. Providers play a big role, and there will be a phone service center. So this is just one screenshot of what Accenture is designing, which up at the top you would type in just a few things. This is anonymous shopping to get a sense of what might you be eligible for in January 2014. So household size, how many people, anyone pregnant, anyone disabled, and then it would pop up, well, you may qualify for discounts in the exchange. And then if you're interested, you click on that and then you keep going through the whole process. So all of this is being designed now. And I'll leave it at that. And thank you.